Talk about respiratory emergencies. You guys want to talk about some science things real quick before we dive into the book and the slideshow? I think if I could give you guys a little better understanding on some anatomy and physiology, that'll make understanding the medical emergencies a little easier, okay? So when we talk about breathing respiratory emergencies, what do you guys think about? Lungs. Anything else? The heart. You're exactly right. So when we breathe, there's two parts to ventilation, right? There's inhaling and exhaling, and then there's something called perfusion, okay? In the medical world, we call that the VQ. The Q stands for perfusion, okay? So the V stands for ventilations, in and out, but you're not going to get, what's the definition of shock? Has anybody talked to you guys about that? Shock in its simplest form is the inability to get oxygen to tissue, okay? So if you're in a shock state, you're not moving oxygen around the body the way you're supposed to. Does that make sense? All right. And that's the perfusion part of it. That's what perfusion means, delivering oxygen to tissue, okay? So you have to have two things in order to properly oxygenate the body. You have to have lungs that are working in and out and a heart that's moving it around. Make sense so far? All right, over here on our anatomically correct heart, you guys have obviously talked about how blood flows through the heart, right? Okay, it goes in through the right atria, down into the right ventricle, then out the pulmonary artery. Fun fact, the pulmonary artery is the only artery in the body that carries deoxygenated blood. Did they tell you that? That's because it hasn't gone through the lungs, right? Goes through the lung spaces and then back down into the left atria, left ventricle, and then out into the body, correct? You guys, when you inhale, air goes into your lungs, goes down through the bronchioles, then where does it go? Have you guys heard the term alveoli? Right? Down at the very bottom of your lungs, there's the alveoli. Do you know what it looks like? It looks like popcorn, right? So we've got my anatomically correct alveoli. And at the lowest levels of your vasculature is something called capillaries, okay? Capillaries are where the oxygen and the oxygen is onloaded and the CO2 is offloaded, okay? You guys understand how oxygen becomes CO2? A little bit, yes, no, maybe a little bit. So what happens in respiratory emergencies is a lot of times your alveoli are not going to be functioning properly, okay? So from there, we're going to talk about who can name off all the meds you guys can give. As an EMT basic at the national level, can we talk about the meds you guys can give? Name one. Charcoal. We're just going to write that. Nitro. What's that? Narcan. Okay. Aspirin is just known as ASA. What else? What's that? Epi. Okay. Is that IM or IV or what? IM at your level, right? What else, guys? Sure, I like that. Anything else? Come on, there's a big one in there, and it pertains to respiratory emergencies. Good. I'm just gonna do that. All right. Is there anything else? I miss anything? 1, 2, 3, 4, 5, 6, 7. You guys allowed to CPAP? Basics allowed to CPAP at the national level now?
I got to look at it because it's one of those ones that's possible.
Okay.
It's in that.
Okay. We'll go ahead. Okay. A little sugar. we're going to talk about CPAP just in case. Okay. All right. And the reason why I wanted to know that, because what I'm about to teach you, or what we're about to go over, is going to pertain to your oxygen, albuterol, CPAP, and then that's it for airway drugs for you guys. Okay. So part of your central nervous system is something known as the autonomic nervous system. Now, I'm going to write this down in a way that you guys will be able to look at it and remember it. I would suggest writing it down because it'll help you study. The autonomic nervous system, guys, is made up of two sides. It's made up, I'm just going to do it on this, on another one. Any ideas what your guys' autonomic nervous system is made up of? Good, good. So we'll bring it down. We'll just say this is your sympathetic and your parasympathetic. All right. If you were going to break down characteristics of the sympathetic or the parasympathetic side of your autonomic nervous system, what are you going to see? For the sympathetic side, what kind of body responses are you going to see from that? Any idea? Sure. What else? What's that? Adrenaline. What does adrenaline cause? Causes you to go fast, right? Your eyes dilate, your lungs open up, your blood pressure goes up, your heart rate goes up. Your intestines actually slow down because of that, because it's letting all those other systems work. So this is your fight, flight, freeze, and submit side. So if you're in full sympathetic mode, you're going to do all your body's going to want to do all of that stuff. Okay, depending on how your body is put together. But does that make sense so far? If someone scares you, you go into full sympathetic tone. You get an increase in heart rate. Your lungs dilate, right? Your blood pressure goes up, and you're ready to fight, right? Or you're ready to run. Okay. So if you're going to do a 180 of that on the parasympathetic side, what do you think some signs and symptoms of being parasympathetic are? Anything? It's literally the opposite of fight, flight, freeze, and submit. It's going to be feed, breed, rest, and repair. Okay? So when you're sleeping, you're parasympathetic. When you wake up and your alarm clock goes off, you know how you're really groggy for like the first 30 minutes? It just sucks and you're trying to like get going. That's because your parasympathetic system is still turned on. Okay? And when you start to wake up without the use of coffee or any type of stimulants, when you start to wake up and get going, then you become more sympathetic and your body, your nervous system kind of evens out. Does that make sense so far? Okay. And what I'm about to tell you is what's pertinent to your guys' meds that we were talking about earlier. Somebody look up in their book and tell me what classification albuterol is. Whoever finds it first is the winner. Okay, never mind. That guy knows it. So it's a bronchodilator. It's also a sympathomimetic. Does anybody know what mimetic stands for? Mimetic means copy. So if you see something that like a medication classification. It's a mimetic, a sympathomimetic. Mimetic means copy. It copies the sympathetic nervous system. So if you give a medication like albuterol, you're going to cause these effects to that patient. Does that make sense? You're going to put them into more of a sympathetic side. And part of the bronchodilation in the sympathetic tone, as he was talking about, we give albuterol for what? Can anybody tell me what kind of signs and symptoms we see in a patient that needs albuterol? Wheezing, bronchoconstriction, right? So during asthma, the bronchioles clamp down and make it really hard for the patient to get air out. But so you have the sympathetic side and the parasympathetic side. We're going to do just a little more science, and I promise we'll get to the slides, okay? I know we're getting into the weeds a little bit. But he said it's a bronchodilator. It's also a beta-2 agonist. Everything in our body has receptors, okay? All the cells in your body have receptors. Basically, receptors are a garage. Like, we'll just call this the cell right here. And then it's got a little receptor, okay? When albuterol hits that receptor, the cell goes into a sympathetic tone. Does that make sense a little bit? Okay. As far as the sympathetic side goes, this is also known as your adrenergic side. Sorry, my handwriting sucks. But there's 3 main adrenergic receptors in paramedicine or in our field of work, okay? There's the beta-1 receptor, the beta-2 receptor, and the alpha-1 receptor. Albuterol acts on the beta-2 receptors, and that causes bronchodilation. You with me so far? Does anybody have any questions? I know this is really getting into the weeds, but I promise if we can get this down, the rest of this stuff is easy and it makes sense. Okay? So on the adrenergic side, when you're given albuterol, and since it's a sympathomimetic, you're getting these kinds of signs and symptoms. You're encouraging this stuff for your patient. Does that make sense so far? Okay. The other side is called the cholinergic side. That's something we don't need to worry about right now. If you guys go to EMTA class, you guys start learning about the parasympathetic and parasympatholytics when you give meds like Atrovent with your albuterol. Does anybody know what a duoneb is? This guy does. A lot of paramedics will give duonebs, and that has both meds in it, but one acts on this side and shuts it off. So this side can show more of its face. It's kind of like a brake and a gas. Does that make sense? So, any questions so far? All right, let's get into the slides. Okay, cool. And I just hit that play button. What's that? Okay. All right, let's talk about respiration, breathing difficulty, respiratory conditions, the prescribed inhaler, and small volume nebs. All right, A&P. So this basically talks about how air moves through your lungs, okay? So when you take a breath, negative pressure is used to move air in, and positive pressure is used to move air out. You remember the alveoli I drew, the anatomically correct popcorn? That has to be stented open, okay? If at any time it collapses, oxygen can't onload and CO2 can't offload, okay? So that's the positive pressure. You always have some type of positive pressure inside your chest unless you have a disease that stops you from completing that positive pressure. And it holds that alveoli open. That way, O2 can onload and CO2 can offload. Make sense so far? All right. The changes in pressure are generated by contraction, relaxation of the respiratory system. When you take a deep breath in, your diaphragm does what? For adults, your diaphragm moves up. Yeah, it moves up into your chest, allows your chest to expand. It creates a negative vacuum, okay? And then you exhale, and then your diaphragm what that does is it relaxes and it goes back down, and that's where the air escapes from your chest. Make sense? You guys with me? Okay. All right. Relaxed. See where the diaphragm's at during contraction? Oh, it goes down. I said it totally backwards. I'm sorry. When you breathe in, your diaphragm settles to the bottom, and then when you exhale, it settles back up. I know it doesn't make any sense in your head. That's why I messed it up the first time. All right. Inspiration is an active process. What does that mean by active process? What's that? Yeah, like, okay, it costs something. Okay. It costs your body energy to actively breathe. To exhale, it costs nothing. You guys, is there anybody who runs in here? Right? Running uphill sucks, but running downhill is free, right? Or sit-ups. When you go to sit up, that costs you something, but going back down, gravity is free, right? So it's a little easier. Does that make sense? So the active inspiration is where your body uses energy, and that's known as ATP. That cell creates energy, and it's important to respiratory emergencies, and that's called aerobic activity. It means you use oxygen to create that energy, which you use to breathe. Does that make sense? Air, all right, diaphragm lower, and then we've already talked about that. We've talked about this. Expiration is a passive process. It costs your body nothing to just exhale. Make sense? Now, when we start getting into emergencies and the patient starts to actively exhale, you know you're in a bad spot because they're actively trying to remove air from their lungs. Size of the chest cavity decrease, air flows out of lungs. All right, breathing sufficient to support life. Signs: generally normal mental status, moving air when breathing. Ability to speak relatively normally without having to catch their breath. Normal color, oxygen sats, typically in normal range. You guys, I can look at everybody in this room and tell that you're all good as far as your breathing goes. Make sense? All right, that's what adequate breathing. That's another thing you guys need to pay attention to when you walk in on a scene. There's something that in the field we like to call sick or not sick. The more calls you guys go to, the better you're going to get at walking in and seeing a patient across the room and realizing right then and there that that patient is having an emergency or that patient is not. That's part of your assessment skills. Does that make sense? But recognizing whether or not someone can adequately breathe is a big tool for that part of your toolbox. Okay? That sick, not sick from 15 feet away is going to dictate how the rest of your call goes. Okay? Adequate breathing. What's the normal rest rate for an adult, guys? 12 to 20. All right. 18 to 30 for kids, 30 to 60 for infants. Rhythms regular and breath sounds normally present and equal. Have you guys gone over breath sounds yet? Anything? Okay. 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 A big deal for us as providers, right? The stethoscopes they gave you, it's not just jewelry, all right? Anytime you have a patient who is in respiratory distress, having some type of respiratory breathing problem, you need to put the scope on them. Because when you listen to lung sounds, all the different lung sounds are going to tell you what's wrong with that patient. Wheezing sounds different than rhonchi. Rhonchi sounds different than rales. And then when you can differentiate, and there's YouTube videos. In your spare time, I want you to get on YouTube and listen to breath sounds. Breath sounds are like EKGs. If you listen to enough normal ones, you're gonna know what a bad one sounds like. Okay. For albuterol, what's albuterol given for? I think you said it earlier. Wheezes, right? Yeah. We give albuterol for wheezes and bronchial constriction, right? Bronchial constriction causes the wheezes. So it's kind of synonymous a little bit. But sometimes you can have bronchial constriction where you don't have wheezes. That's something we can talk about later. But in your spare time, get on YouTube and listen to lung sounds. And then every patient in the beginning, you should be putting your scope on every patient. That way you get used to hearing what normal sounds like. And then what unnormal sounds like too, okay? All right. All right. Inadequate breathing. Breathing not sufficient enough to support life. Rates out of the normal range. It's either too fast, too slow, or regular. They can't speak. And silent chest. Let's talk about rates outside of normal ranges. Can any of you tell me when you think somebody might be breathing way too fast? That's not on purpose, like not because they're running. Anybody have any idea of some type of disease process that might cause you to breathe way too fast? COPD, sure. Yeah, at the compensating point, sure. I like that. Any idea any disease processes that might cause us to breathe too slow? Cancer, sure. End stages was when you start to go downhill, right? Anything else? Okay. Inability to speak. That's part of that 15-foot thing I was telling you guys about earlier. If you're walking up on a patient and he's talking to, like, say fire gets there first and fire's talking to him, and you see look down at that guy and he's tripoding and his sentences are only have 2 words in them, you know he's a sick patient because he just can't get the words out. All right, let's talk about silent chest real quick. Has anybody heard of that? It's where you go to listen to the chest and there's nothing moving. There's no inhalation, there's no exhalation, it's just dead. You know what causes that? You remember that energy I was telling you guys about earlier? Remember how the cell makes ATP? And you know how it costs you something? It costs you energy to breathe in. That patient with the silent chest has been working so hard, there's no more energy left. Okay? There's no more energy left to inhale. They just can't move any more air. There's just their energy is depleted. If you ever have a patient, and this is just a little fun fact for when you're on the street, if you ever have a patient who has asthma and they're getting sleepy, the next thing that comes after that is respiratory arrest. If they're not moving air and they're tired, the next thing you're going to be doing is bagging this patient back up and possibly thumping on their chest. So just so you know, just for you in the future, if you ever have an asthma patient tell you they're sleepy, it's time for you to get to work. Okay. All right. Cool. All right. Signs: low 2 sats despite supplemental oxygen. Agonal respirations. What are agonal? Does anybody know what those are? Those are end of life respirations. This patient is dying. Okay. Irregular rhythm, diminished or absent lung sounds, poor tidal volumes. Okay, let's talk about the irregular rhythm. Remember in the beginning when I said that the respiratory system is made up of 2 things, the lungs and the heart? Okay, irregular rhythms are going to push blood around the body in a less than adequate way. Does that make sense? Now, as EMT basics, are they allowed to monitor? They're not allowed to monitor 4 leads at all, right? Okay. So what's fun about being a basic is tricks like this. You can feel 4 different types of pulses when you feel someone's pulse. You can feel a slow pulse, you can feel a normal pulse, you can feel a fast pulse, and you can feel AFib. AFib is irregularly irregular. You got to feel it and there's no rhythm to it. That's because that patient is in AFib. And everybody that's over the age of 65 is a card-carrying member of the AFib club. Okay? So an irregular rhythm will cause the blood flow around the body to be inadequate. And if blood flow is inadequate, oxygen delivery is inadequate, which means perfusion, and then they're in a shock-like state. Make sense? Cool. Diminished or absent lung sounds, we talked about those, and poor tidal volumes. Tidal volumes is just the amount of air you breathe in and out, okay, in one breath. Minute ventilations is how much you breathe in and out in a minute. Your big ambo bags or your BVMs, anybody have any idea how much air those have in them? The adult ones. Okay, I like it. And they get and as you decrease in size, they get smaller, and that's just implied, right? An adult's normal Tidal volume is anywhere between 6 to 8 cc's per kilo. So that's about 6 cc's per kilo for easy math. All right, pediatric note. Structure of an infant and a child's airway differ from that of an adult. They have smaller airways and are easily obstructed, proportionally larger tongues, smaller, softer, more flexible tracheas, less developed, less rigid cricoid cartilage, and heavy dependence on diaphragm for respiration. Kids, little kids, breathe with their bellies. You know how when you take a deep breath, like we said, your diaphragm shell goes down, that causes the reverse vacuum. Kids, they breathe with their bellies. Their diaphragms haven't developed to a point where they can use those. I still breathe with my belly, I feel like sometimes. Larger tongues, that's a big problem, okay? The reason why bigger tongues are a problem because what kind of adjuncts do you guys get to use to help you bag a patient up? Did you guys talk about OPAs and MPAs? Okay, so that larger tongue, those OPAs, the tongues are going to get in the way, right? More flexible trachea, less developed. All right, cool. Any questions about this so far? Kids are just shaped weird. If you drop a kid, they'll fall head first because their heads are bigger, right? So kids' anatomy is just so much different than adults. All right, signs of inadequate breathing in infants and children. All right, nasal flaring, grunting, seesaw breathing, and retractions. Nasal flaring. If kids are having a hard time breathing, kids, if they're little enough, they can't tell you what's wrong with them, right? So that's part of that 15-foot assessment of your patient, okay? Mama's holding this lifeless kid in her arms, and you look and you see he's obtunded. Obtunded means kind of out of it, lethargic, all right? And his nares are really wide open, and his respirate is stupid fast or slow. The way the body works is we will compensate by increasing things like breathing and your respiration rate until we can't no more, till that energy runs out, like on the silent chest, and then the body will start to go downhill, and then you'll start seeing slow respirations, agonal breathing, stuff like that at the end, right? So if you get to a patient and their respirate is high, sometimes that's a good thing. That means they're still compensating. Okay, grunting, kids will grunt. It's just because they're belly breathing, seesaw breathing, and retractions. Do you know? Anybody know what? Does everybody know what retractions are? So retractions are when you look at baby's rib cage. It's gonna the outside, the skin on the outside of their chest is gonna be sunken in. It's gonna look like waves. And that's because that baby's using the crap out of their chest wall to try and breathe, right? And then other signs and symptoms would be, cyanosis, obvious hypoxia, things like that. All right, inadequate breathing, assisted ventilation with supplemental oxygen, pocket face mask with supplemental O2, 2 rescue bag valve mask with supplemental O2, 1 rescue BVM with supplemental O2. Have we gone over 2 and 1? Okay, cool. Any questions about this slide, guys? Cool. All right. Adequate and inadequate artificial ventilation. Chest rise and fall should be visible with each breath. That is your gold standard. If you're bagging a patient and you don't see chest rise, that means something's not right. Okay? That means if you might have a bad seal, the equipment might be not working right, or you have some type of obstruction, but that should be your gold standard. Anytime you squeeze that bag, look at the chest and make sure it's rising, okay? Because that at least means you're getting the ventilation part of the VQ that we were talking about earlier. Does that make sense? All right, these are your vent rates with the BVM, 10 to 12 per minute for adults, 12 to 20 per infants and children. Cool? So it's safe to say if you do 12, you might be good for both. But that's all depending on your medic or if you're running a basic bus. Just don't forget those rates, okay? All right, page 2, increasing pulse rates can indicate inadequate artificial ventilation in adults, right? And then decreasing pulse rates can indicate inadequate artificial ventilation in peds patients. So the littler you get as far as pediatrics go, their heart rate is dependent on the oxygen. So if you have a baby or an infant and you see them start to get Brady or their heart rate slows down, that means they need oxygen. You give them oxygen, a lot of times you can fix the problem, and either via through the BVM. Adults are the exact opposite. Their pulse rates will go up when they need oxygen, because if you think about it, if you're not getting enough oxygen, your heart is going to turn up in order to try and compensate for that lack of oxygen, right? All right, think about it one. All right, this is a question for you guys. How might you recognize the progression from adequate breathing to inadequate breathing in the assessment of your patient, and how might your patient change during this transition? Kind of talked about this a little bit. Does somebody want to give this a shot? Anybody? Bueller? Bueller? A lot of you guys are too young to know that movie. Yeah, whatever. You're like 36. Well, come on now. Okay, good. I like that. Skin color. Okay, what would skin color? What could? What's that? Sure. Cyanotic, hypoxic. Things with babies, they're going to get blue around their lips much faster than adults will. So if you see a blue baby, it's time to start bagging them, right? That's how they're going to change during the transition. All right. Perfect. That's a great indicator of perfusion for kids. You guys talk about triage yet or anything like that? Okay. We'll if we get a chance, we'll talk about that. All right. Breathing difficulty. All right. Patient subjective perception, feeling of labor or difficulty breathing. If a patient can speak and they can't breathe, they're going to tell you. Okay. That's like their number one goal in life is to fix whatever that problem is, right? ABCs, airways first, right? That physiologically, that's going to be most of the time, that's going to be in the first thing also is airway, right? Amount of distress felt may or may not reflect actual severity of condition. All right. So that's true. As patients get older, elderly patients, they don't feel pain as much, especially women. So a woman can tell you, yeah, she's okay. She's just got a little bit of pain in her chest and she's in a full-blown MI. But she's not acting like I would, like a baby, if I was in a full MI, right? So there's that tripoding. Assess to be sure that the patient meets criteria for CPAP. We'll talk about CPAP here in a minute. But look at his position, right? That's called the tripod position, either right like that or down on his elbows. Just let's look in his face. And then they can't breathe. 1 or 2 word sentences, things like that. Let's talk about CPAP real quick. Does anybody know what CPAP stands for? Perfect. Good. Do you know what we use it for? What's that? Sleep apnea? Yep, sure. To activate what? Yeah, sure. Perfect. Okay, that's the continuous positive airway pressure. So when you breathe in, do you remember how I said you always leave a little pressure in your chest? That holds those alveoli open. Can anybody think of a disease process that affects the alveoli directly? What? Sure. Now, COPD is made up of 2 diseases. Do you know what they are? Emphysema and bronchiolitis. Anybody in this room could have COPD temporarily if you got bronchiolitis. Bronchiolitis is basically just air trapping and mucus plugs. You got sick. Emphysema, though, is specific to the alveoli. All right. Your alveoli got something called surfactant. It's basically lung lube. Yeah, I got kids too. Lung lube. And that lung lube makes it so the alveoli can open up and stretch out. Smoking for 20 or 30 years is going to ruin that surfactant, and then the alveoli will collapse, and then they stick together, and it's hard to get them to open up. When you go to put your scope on a patient and you hear lots of popping, like little, like pop rocks in their chest, that's called crackles. And that's because they don't have very good alveoli, and that's because those alveoli are popping open from the bag or them breathing or whatever. The crackles are popping those alveoli back on, and it's really cool to hear. Sucks for them, but it's really cool to hear because it tells you which way your treatment path is going to go down. Does that make sense so far? So emphysema is is smokers, right? They've ruined the surfactant. There's other things that could cause surfactant to be messed up, like drowning. Water will wash that out. And then bronchiolitis, which is bronchiolitis and asthma are very similar in etiology. It's all mucus plugs and air trapping. The bronchoconstriction makes it so the air can get into the lungs, but traps it, makes it so they can't exhale. Remember, exhalation is free. Makes sense? It doesn't cost any energy. But on the flip side of that, if you're trapping air and you can't get it out, then the free exhalation part of it doesn't benefit the patient. Does that make sense? You guys with me? You guys need a break or anything? Okay. All right, onset. So this is your OPQRST stuff, right? These are the questions you're going to ask the patient if they can speak. If you come up on a patient who can't breathe, what's one of the best ways to get information on a call? Family members, people that are around, right? Like, when did this start happening? What the onset? Provocation. What were you doing when this came on? A lot of times what provoked the situation is going to dictate what their disease process is. Okay. If they're asthmatic or no, let's not use asthmatic. If they're COPD, you're going to know what caused the breathing issue. It was 20 or 30 years of smoking, right? But if they have asthma, that means there's some type of, they inhaled something that caused a response, an inflammatory response in their lungs, right? And then quality. Do you have a cough? Are you bringing anything up with it? Remember what I said, bronchiolitis is about mucus plugs and air trapping? Well, if they're coughing up phlegm and just giant loogies, it could be because they just spent the past month sick, right? But if they're coughing up something else like pink frothy sputum, that means that they're having a CHF problem and that the blood pressure in their lungs is too high and blood is leaking out of those alveoli into the lungs and they're coughing it up and it looks like pink loogies, okay? And that is an indication for CPAP, which we'll talk about when we get to it. All right, and radiation. Do you have pain or discomfort anywhere else in your body? Does it seem to spread to any other part of your body? Can anybody tell me a patient that you might see where they're going to have pain that moves around the body a little bit, that started somewhere and then ended up here? Anything? Blood, maybe. Chest pain. A lot of times our chest pain is a true MI. A lot of times they'll have pain in their shoulder too, right? Does anybody know why that is? That's because your heart and your shoulder share the same nerve bundle. So if the heart is screaming because it's in the middle of a heart attack, it's going to affect those nerves. Also, a lot of times appendix, when the appendix has issues, will start on one side of the abdomen, and as it gets worse, we'll move to the side of where the appendix is at before it ruptures. So radiation is a big deal. Ask them, did it start somewhere? Has it ended up somewhere else? As far as respiratory emergencies and radiation, if you position a patient in a different position and breathing gets easier or not at all, it's going to help you decide if the pain or the chest, if the difficulty breathing doesn't change with positional stuff, it could point to it's a respiratory problem, right? But if the chest pain goes away when it's positional, it could be something else. Does that make sense so far? Severity on a scale, always ask them, how bad is the pain? 1 being not so bad, 10 being the worst pain in your life. A lot of times they'll say it's an 8 or 9 or 15, depending on, and then time. And how long have you had this feeling? Time is a big deal in medicine. Okay. The doctors want to know, when did this start? All of them, for all sorts of reasons. We don't have to talk about all those right now, but time is a big deal. If they've been feeling like this way for 3 weeks, you know they're probably not going to die before you get to the hospital. But if it came on sudden, fast, in a hurry, and their 1 to 10 scale is a 20, it's time to pick up the pace. That makes sense. All right. Observing. Altered mental status, unusual anatomy, barrel chest, patient position, tripod position, sitting with feet dangling and leaning forward. All right. Altered mental status, lack of oxygen. There's lots of reasons that cause altered mental status. Okay. We can do that. Can I use another piece of paper? All right. So when I first became a paramedic, I memorized this because I could never remember all of the different reasons why someone could be altered. But if you memorize this too, 95% of the reasons why a patient is altered, you'll be able to. So it's pretty easy. It's shot, triple H, IC, stroke, head injuries, overdose, toxic ingestion, or swallowed pills, or some type of toxic ingestion. Hypoxia, that's going to be a big one for you guys. Hypoxia, hypovolemia, hypoglycemia, infection, and cardiac. I know that's a lot, but it will help you a lot in your assessments of the patient. It's going to help you narrow down the majority of the reasons why they could be altered. Because in our field, the deeper you guys go and the more levels you guys complete, the more you get into that stuff. Okay. Well, hypoxia is going to be a big one for us. Hypovolemia is a big one for you guys to recognize, because if someone has not enough volume, there's not enough blood to push around the oxygen. Make sense? Overdoses. You guys can give Narcan. All right. So that's a big one. And charcoal. Head injuries. It's important for you guys to identify them. Strokes. That's also important. So it's all good. I promise. If you learn it and memorize it, it'll make you better. And it's just something a long time ago, I looked up all the things that caused altered mental status, and that's what I put together. If you can think of a better acronym than SHOT triple HIC, go ahead. So, all right. Tripoding, we talked about, leaning forward. All right. Pale, cyanotic, flesh skin, pedal edema. What is pedal edema, guys? Swelling of the extremities of feet, right? Sacral edema, oxygen sats or pulse ox is reading less than 95% on a pulse oximeter. Cool. So this is just so let's look at him real quick. It says he's altered. It says he's cyanotic, straining neck and facial muscles, because he's using, all of you guys right now aren't doing that much work to breathe, right? When you get into these situations where you're having a hard time breathing, you're going to start using accessory muscles. And that's where the straining neck and facial muscles, tightening in the chest, stabbing chest pains in some patients, straining intercostal muscles. You guys notice how you can see his ribs? I mean, he's a fairly skinny guy, but those are the chest wall retractions. You're going to see those in little kids, and that's going to be a big indicator that the kid's having trouble. Okay. Numbness or tingling in hands and feet. That's because he's cold. He's not getting oxygen to those parts of his body anymore. Because when your body goes into shock, it shunts all of the blood to your core. Okay, cool. Flaring nostrils, pursed lips. We go back one slide. We don't have to. It talked about barrel chest. All right. Blue and bloated, and pink puffers is what falls under your COPD category. Okay. If they're pink puffers, they're going to be skinny and they're going to do pursed lip breathing. Do you remember when she talked about CPAP, not positive end expiratory pressure or whatever? CPAP, continuous positive expiratory pressure. That pressure that we leave in our lungs, I'm talking about, to keep the alveoli open. Guys who have emphysema real bad will breathe through their lips. They'll purse their lips. And what that's doing, they don't even do it on purpose. But what that does is it causes those alveoli to stay standing open. It's called they're peeping. They're causing the alveoli to stay open by pushing against the cheeks when they breathe. Does that make sense? And blue and bloated is another signs and symptoms of your guys with bronchitis, because they use so much of their chest muscles to breathe that their chest gets bigger, right? So if you don't want to hit the gym, get bronchitis, right? So and they're blue because the blood is very deoxygenated. So you know how your veins are blue, right? They're very deoxygenated. So and then tripoding. Noisy breathing, audible wheezing, gurgling, snoring, stridor, coughing. You good? Okay. No, it's all good. Can anybody tell me what stridor is? It's like it's a whistle, but stridor means there's an upper airway obstruction. And your kids with epiglottitis and croup can present with that. And it's a weird sound. It's one of those breath sounds I want you to listen to on YouTube, because stridor means there's an obstruction up top somewhere, whether it's choking or constriction, like in our croup patients. Okay. Stridor is a big deal. And coughing. Everybody coughs when they've got junk in their chest. Snoring, gurgling, and wheezing. Audible wheezing, though, yeah, that's part of the 15-foot thing that I was talking about earlier. You look at your patient, you can hear them wheezing from across the room. It's time to go to work. You know what I mean? So, lung sounds on both sides during inspiration and expiration. I don't like to auscultate lung sounds on the way you're supposed to on women because of breasts. So can you stand up for me real quick? You're supposed to listen to lung sounds in 8 places. 1, 2, 3, 4, and then the same on the back. So if you just turn this way, so your back is towards everybody. Yeah. So you're gonna listen up high. 1, 2, 3, 4. Okay. On women, I'll do the top ones. I won't do the bottom ones because then then there's tissue in the way and stuff like that. But you can listen. You'll hear the stridor up high. You'll hear wheezes and rails and rhonchi down low. Okay. All right. So this is him just showing you guys how to do the auscultation. High pitch wheezes are high pitched sounds created by air moving through narrow air spaces. Crackles are fine crackles or bubbling sound heard on inspiration and caused by fluid in alveoli or by opening and closing of the alveoli. Okay. Make sense so far? The stuff we kind of already talked about. I told you I jump around a lot. Sorry. Rhonchi, low-pitched lung sounds resembling snoring or rattling caused by secretions in the large airways. What's cool about rhonchi, this is one of the funnest lung sounds to listen to, all right? Because it's going to sound like rocks stacking under the water. But if you have them cough and it goes away, it moved, which means they have rhonchi. That means all those loogies are moving around in their chest, right? And stridor is a high-pitched upper airway sound indicating partial obstruction of the trachea or larynx. Stridor is going to be a big problem in your kids, okay? And it's a medical emergency. Stridor is not good in kids, okay? If you hear it in adults, it's not terrible, but it's not as much of an emergency as it is in kids, okay? All right, evaluate the vital signs, which may include increased or decreased pulse rate, changes in breathing rate, changes in breathing rhythm, hypertension or hypotension? Um, Hypertension and hypotension will tell you just a lot about where the patient's at in their compensate when they're compensating. Okay, everybody, adults especially, when you're having a tough time and you're struggling, your blood pressure goes up. When your body runs out of energy, it goes down, and then after it goes down, death follows. Make sense? So where someone's blood pressure at will help you determine where they're at in the process of either are they compensating and good or are they no longer compensating and it's time for us to do work. Make sense? All right, breathing difficulty, assure adequate ventilations. If breathing's inadequate, make it adequate, right? There's nothing wrong with putting a bag on a patient's face. It costs the service nothing. And if you get on a patient and you determine that their breathing is not adequate, there's nothing that says you can't help them in any situation. And then the bag goes in the trash, right? It's always good to bag when you're in doubt that the patient, if you're not sure whether the patient needs a bag or don't, it's probably good to just bag them. All right. And you can do this while they're conscious. It's called track breathing. Basically, you watch them breathe. When they take a breath, you squeeze the bag and you help them. Does that make sense? Track breathing is one of my favorite things to do. But yeah, if breathing is inadequate, help them make it adequate, whether it be a non-rebreather or a nasal cannula or a BVM. All right, it says it right there. What's the highest you can put a nasal cannula on? What's the highest liters per minute you can put a nasal cannula on someone? 6. What's the least amount that you could start in with a non-rebreather? 10. You're exactly right. 10 to 15 liters on a non-rebreather. And then if you're bagging someone, you should be giving them 15 liters and all the O's. Make sense? Cool. All right. Yep. Settings is defining your protocols. All right. Place patient in a position of comfort. Administer prescribed inhaler and administer continuous positive airway pressure, CPAP. All right. Let's talk about CPAP real quick. She knew what the definition of it, and she knew certain times when we use it. What are some indications for CPAP? Say your patient is breathing adequately on their own, their ventilations are adequate, but their pulse ox and they're not getting better. You try the non-rebreather, it's not getting better. Their pulse ox is still in the tank, it's not coming up. What's that? Then they're going to need some pressure, right? Let's actually, before we talk about the indications, what's more important about CPAP is the contraindications. And this is something you guys are going to need to remember for national. All right. When are the 2 times you are never allowed to put a patient on CPAP? Take guesses. I don't care. No, we'll talk about it. Any ideas? Yeah, you definitely can't CPAP an intubated patient. I like that. Not one of the 2 though. Any other ideas? No, we do CPAP on COPD all the time. So you cannot put CPAP on a patient if they have a systolic blood pressure less than 90. Okay. Does anybody want to take a guess at why that is? When you place somebody on positive pressure ventilation or CPAP or BiPAP, you inflate the lungs. Well, there's only so much space in your chest cavity. Okay. So when you inflate these lungs real big and you've got those alveoli open wide open, that's going to put pressure on the heart. And we put pressure on the heart, it slows down. Makes sense so far? And because of the slowing, and then the blood pressure reacts accordingly. Okay. So you could tank that patient's heart rate and the blood pressure by filling the chest up with pressure. And the second contraindication for CPAP is going to be they can't breathe for themselves. They can't take adequate breaths on their own. There's no point in putting a whole lot of pressure to a patient if they're not going to breathe it in. Does that make sense, guys? So, all right, cool. All right, well, crap, I probably already covered this. All right, continuous positive airway pressure in a form of non-invasive positive pressure ventilation, consisting of a mask and a means of blowing oxygen or air into the mask. Blowing oxygen or air continuously at low pressure into airway prevents the alveoli from collapsing. It can prevent fluid from entering the alveoli and the pulmonary edema. So I'm going to tell you something, it's not quite medically accurate, but it helped me when I was a basic. You remember when I told you about the people coughing up the pink frothy sputum? That's blood, right? Well, the way I learned it was the CPAP puts all that pressure in the lungs and forces the blood back down into the vasculature, if that makes sense, and forces all that fluid back into the body. Basically, like if you had a clogged drain, CPAP is the part that pushes the water down the drain. That makes sense. All right, common use is pulmonary edema. That's what we were just talking about. Drowning, asthma and COPD, respiratory failure in general. There's been a lot of times where I've thrown a patient on CPAP and I hadn't figured out what was wrong with them yet. I just knew that they needed it, right? Don't get caught up in the why sometimes when you're doing your ABCs. Life threats first. And a patient that's not breathing adequately is a life threat. Fix it while you're trying to figure out the problem, right? All right, drowning's an interesting one. Drowning will also help push out the edema because edema is just fluid and drowning is water, right? Asthma and COPD, we're good. Contras, severe altered mental status and lack of normal spontaneous respiration rate. Those are kind of synonymous. If you're severely altered, you're not going to be breathing normally most of the time anyway, right? Inability to sit up and hypotension and shock. So blood pressure, like we saw, right? Any questions so far, guys? Okay. What slide number are we on, sir? Oh, wow. I'm sorry. What's up?
We'll take a break.
We're going to take a break in a minute.
How does that work with the drowning? Wouldn't you want to get that water out of the room?
So you would, but if you were to be on scene and you were to hook up the Hoover to their mouth, people are going to look at you funny. Hoover is a type of vacuum.
She's too young for that.
Oh, okay. No, so what the CPAP does is it blows up all the alveoli in the lungs that aren't quite submerged in water, all the extra alveoli, and it helps oxygenate the patient that way, and it helps push some of the fluid down. But
Down.
where the fluid goes, if it's water, I think it stays in there until you get to the hospital, and then there's something called a bronch, and that's where the doctors can go in and clean it out. But
It does push some of it back into the bloodstream.
some.
So it does help, like the alveoli that is in place. If there's just a little bit of water in there, you'll push that into the bloodstream and allow it to be absorbed throughout the body.
Okay.
Yeah. And then drowning also ruins that surfactant that we talked about, the lung lube. And that makes it so the alveoli can't open up like a balloon as much because it's dry, essentially. If that makes sense. So, cool. All right. Contras, nausea, vomiting. The reason why nausea, vomiting is not a good idea for CPAP because they'll just be puking into the mask, and then they could aspirate and it'll be worse. Your breathing problems will get worse. Chest trauma, shock, upper GI bleeding or recent gastric surgery, conditions preventing good mask seal. You got to have good mask seal in order to properly ventilate or help somebody breathe with a CPAP. That makes sense. If you're blowing all that pressure out the sides, it's not doing anything for them. Side effects, hypotension, pneumothorax, increased risk of aspiration, and drying of the corneas, which is drying of your eyes. I'll tell you a real quick story. I had a lady who was tripoding, 2-word sentences. I didn't get anything out of her husband because he's a great historian. And I immediately went to CPAP because she was sat in the 70s and she was struggling. And I was worried she was going to crash on me. Put her on CPAP, get her on the ambulance, and we're taking her to the hospital. She's doing much better. Her heart rate came down, her blood pressure came down, she was breathing better. I had her sats in the low 90s. I'm a hero. And then all of a sudden, she can't breathe anymore. She says, I can't breathe. It hurts on the left side. So I go to listen to her lung sounds again on the ambulance. And I look up at my buddy. I'm like, bro, I can't hear any more lung sounds on that side. And he goes, well, we don't need this anymore. And he rips the CPAP off of her face. What I didn't know was a month before I got her, before I went to her as my patient, she had a lung biopsy. And she couldn't tell me this. She couldn't tell me that she had had a lung biopsy and stuff. What I did was I reopened that hole in her lungs and I caused a pneumothorax. And I was really mad at myself the whole way in. It's like, damn it, I know better. I get in, they drop the patient off. She immediately gets a chest tube. Doc cuts her right there in front of me. And then he looks at me and says, good job. I'm like, what? I just blew up this old lady's lung. He's like, yeah, but you bought her enough time to get to the hospital. So even though I didn't know about the biopsy and I caused a tension pneumo essentially and collapsed her lung, the doc instantly fixed my mistake, but I gave her the time to get to the hospital because she was probably going to crump right there in front of us. So that's a fun story. And drying of the eyes. Explain the procedure to this patient. Sometimes you're going to have patients that have no idea what CPAP is. It's important to tell them what you're doing while you're doing it. That way they're not freaked out by this massive rush of air that's just going to be pushed in their face. Okay. It's like sticking your head out the window at 90 miles an hour and trying to breathe. All right. Start with your lower levels of CPAP. As we get older, our tissues get softer. And if you put an old lady on high pressure right away without titrating her to that, you're going to pop her lung. Okay. Explain the device. We've already covered that. All right. Reassess your patient. You're always reassessing your patients. Always. Some people will define it and say you need to do it every 5 minutes. But in the back of the ambulance, you're not checking your Twitter or your Instagram. You should always be reassessing your patients. Always be looking at them. Always be looking for work. Okay. Raise the CPAP level if there's no relief within a few minutes. So anytime we do something to a patient, we always give it time to see if it's working. And if it is, then you're good. If it's not, then you can either change what you're doing or increase what you're doing. Okay. All right. Reassess. All right. So if this is bad news bears, right? If you've got a patient on CPAP, they're not getting any better and they start to go downhill on you, the last thing you can do for these patients is bag them. Okay. All right, cool. Everybody, 10 minutes. You want to take a break, go use the bathroom? All right, guys, real quick. This is what a CPAP mask looks like, right? A lot of times it comes, well, this one would come like this. What you do, is this clean? Okay.
Yeah.
All right.
Whose mouth are they put?
All right. And what you do is you can set up your straps, and I'll hand this around so you guys can check it out. You set up your straps, and then what you do is you press it up against their face. There we go. What you do is you press it up against their face. Boom, like that. Then you take the strap up and over their head. And then what you do is you tighten up the top ones to where this foam piece is sitting up against the forehead. Okay. And then you tighten it in a way to where there's no mask that the air doesn't escape. Then you do the bottom ones. Okay. Now this is called this is an inline type CPAP. All you're going to do is run an oxygen line from right here to a tank. And whatever you put into here, there's a dial on the side. That's gonna do two things on this one. That's gonna be your PEEP and your liters per minute. Does everybody know what I mean by liters per minute on an oxygen tank? North, south, east, west? Okay. So on this one specifically, if you put in 5 centimeters of water, they're going to also get 5 liters per minute of oxygen. Okay. There's other types of CPAP machines that you have to hook up to your tank directly, and you get to auto dial the CPAP and the liters per minute. This is an easier system, and it's better for EMS because it's kind of a set and forget type thing. And remember what I said about the contraindications and starting low with older people, right? I think the max on this one goes up to 15. Okay. Don't ever put somebody right on 15. It's not going to be the thing. It's like if you put a patient on CPAP and you think if I turn it all the way up to 15, then I'm going to fix them quicker, you could cause injury. Okay. I would suggest starting at 5 centimeters of water and working your way up in increments of 3 to 5. Okay. And be cognizant of their age. As we get older, tissues break down and things don't work as well. Okay. So we don't want to throw Meemaw on 15 right away. Okay.
And what's the minimum amount of PEEP you need to keep the alveoli? Talk about this.
All right. Right. That's your good. That's your intrinsic peak.
That would be the minimum.
Any questions about CPAP? It's a really great tool, and I love it. I love it. Mr. Perry. All right, guys. Let's talk about some respiratory conditions. Okay. COPD. We already covered this real quick. What are the 2 different types of disease processes that make up COPD? Emphysema and bronchitis. Good job. If a patient has emphysema, what are they going to look like? They're going to be pink puffers, remember. Why are they puffing? Yeah, why are they doing the pursed lip breathing though? Yeah. Yep, say it. Good. Good. The pursed lip breathing, you guys should all try it later. It's weird. That they're causing PEEP, the same thing that CPAP is doing, but they do it all the time. They walk around and pursed lip breathe because they're trying to maintain that PEEP. They're trying to keep the alveoli from collapsing and taking away their ability to oxygenate their bodies. Okay. And bronchitis, what do they look like? Come on, guys. We talked about it. They're blue and bloated, right? Why are they bloated? Why do they have big chests? What's that? Yeah. They're using their accessory chest muscles too much, right? And they're getting jacked, right? To an extent. And why are they blue? Yeah, they're in something called polycythemia. That means you have too many red blood cells. When your body senses that you're not getting enough oxygen, the bones will create more red blood cells. And those red blood cells is what picks up the hemoglobin, is what picks up the oxygen, right? And if you can't oxygenate this blood, it's blue, right? Then it's real dark red, right? That's why they're blue and bloated. Now, what are the similarities between bronchitis and asthma? I'm asking you guys these questions because we already went over them, and they're gonna be on your national. What are the 2 things we said that was similar between bronchitis and asthma? Air trapping and what? What?
Bronchitis are constricted.
No, but good try. Mucus plugs. Air trapping and mucus plugs is what makes up bronchitis and asthma. Because the treatment plans for those are similar. And what was air trapping? You said it a second ago. The bronchial constriction. Air trapping makes it so you can't get air out, right? It's trapped. They can't exhale because exhalation is what? It's free, right? It doesn't cost your body anything to exhale like it does to inhale. And that's when it becomes a problem, right? All right. All right, broadcast. We've already talked about this. Most COPD patients are smokers. That a lot of them, they can have lung injuries from like, Agent Orange or what's asbestos, mesothelioma, stuff like that. If you drank the bad water at Fort whatever. All right, chronic bronchitis, bronchial linings inflamed, excess mucus produced. That's those mucus plugs we were talking about. When you smoke, your guys' airways are lined with something called cilia, which are microscopic hairs, right? They're little hairs. I know. She looks at it, she's like, oh, gross. Yeah, yeah, right? But what those little hairs do is it creates something called the mucus elevator, right? And smokers destroy those microscopic hairs in your airway, and that airway acts as little fingers which push the junk up and out of your chest, right? And that's why bronchitis patients have a hard time with mucus plugs because they can't get rid of the loogies. Make sense? All right. We talked about that. So here's your anatomically correct alveoli, and with your mucus plugs and your decreased surface area. All right, I'm going to try and explain something to you, and it's going to be hard to grasp a little bit, but I'm going to try. Okay. Those alveoli, if you think about a balloon, when you blow it up, it gets bigger, right? That is synonymous with the surface area. Okay. And as that surface area gets bigger, that membrane gets thinner. As if you stretch out a piece of Play-Doh, that little string or cheese or whatever gets skinny, right? That's the same thing that happens in your alveoli. When those balloons get blown up, that membrane gets real thin, and that allows oxygen to diffuse into the alveoli easier, and it allows CO2 to offload easier. That's called fixed gas law. Okay. So I don't need to explain that, but has everybody got the balloon concept down? As that membrane gets thinner, oxygen can pass through it easier and CO2 can pass through it easier. Make sense? And that when you have mucus plugs, ruin the surfactant and stent the balloon from opening up all the way, you slow down that oxygen and CO2 from being able to go across that membrane. Make sense? Is everybody with me so far, north and south? Okay. All right, emphysema. The alveoli wall breaks down. Surface area of the respiratory exchange is greatly reduced. That's because the surfactant has ruined the lung lube has ruined the alveoli's ability to stay open. And then when it closes on itself, it gets sticky. And what lung sound are we going to hear when we listen to alveoli popping open? Crackles. Okay? Crackles. All right, loses its elasticity, results in air laden and carbon dioxide being trapped in the lungs, reducing effectiveness of normal breathing. Any questions about that, guys? All right. Asthma. Asthma and bronchitis, like I said, are similar in nature. All right, chronic disease with episodic exacerbations. During an attack, small bronchioles narrow and mucus is overproduced. Results in small airway passages practically closing down, severely restricting airflow. So what happens during an asthma exacerbation? All right, it's kind of like an allergen. We breathe in crap all day long. It just junk from being outside, whatever. And most of us can go along our day without it affecting us at all. Our body reacts normally to it and then filters it and gets rid of it, right? Some people don't have the ability to do that. Some people will go outside, especially in industrial areas or during certain seasons, and they'll breathe in some of this junk, and it causes their body to overreact. Okay, it's like an immune response. You know how you get sick, the bugs in your body get attacked by cells and kills the bug, and then your body gets rid of it, right? Your body will overreact during an asthma exacerbation. There's things called cytokines, and you'll have lots of inflammation. Well, one thing you have when you have lots of inflammation is redness, swelling, and edema. and you'll have fluid buildup, which in most of us, that's a good thing. But in these asthmatics, they overdo it. You know what I mean? They produce too much fluid, too many cytokines, macrophages, science words. They have an overreaction to the thing that most of us it wouldn't even bother us. Make sense? And then all that junk happens to their lungs, and then they have a hard time breathing. Make sense? All right. Asthma, restricted in one direction, inhalation, expanding lungs exert outward pull, increasing diameter of the airway and allowing airflow into the lungs. Exhalation, that's the opposite. But the one thing you should take away from this is they can't get air out. Okay, that bronchoconstriction, because we actively breathe, right? We can breathe in all that air. It's getting rid of it is hard because it doesn't cost us anything to exhale, but that works against us in asthma. Everybody with me so far? Okay. Pulmonary edema, abnormal accumulation of fluid in the alveoli. Patients with CHF may experience difficulty breathing because of this. One more time, pulmonary edema can be anything from drowning or blood seeping into the lungs because the heart isn't working well anymore. Heart failure causes pulmonary edema. When you guys talked about the heart, did you guys talk about it being two different pumps? Did you? So you have the right side and the left side. The right side pushes blood to the lungs, right? If the right side isn't pushing blood to the lungs effectively, what's going to happen is the blood pressure, the vessels in the lungs are going to clamp down, meaning the blood pressure in the lungs is going to go up. Now, think of all the vessels in your lungs as a hose. It's got holes in it, kind of like a sponge. Okay, it's not like a perfect hose. All right. And it needs a perfect blood pressure range in order to push blood through them without it leaking. If the pressure goes up too high, blood will leak into the lungs through those holes in the pulmonary artery. Does that make sense? And then when the pressure goes up, and then those capillaries, they fill with blood, leaches out, they're coughing up pink frothy sputum. Okay? All right. Oh, I just said that. Fluid crosses. All right. Dyspnea. What's dyspnea mean? What is dyspnea? Is a medical terminology that you guys should memorize. What's that?
Is that painful breathing?
Difficult breathing. Is that what you were going to say? Okay. Common signs and symptoms of pulmonary edema: dyspnea, anxiety, pale and sweaty skin, tachycardia, hypertension, respirations are rapid and labored, and low oxygen saturation. Basically, that's all the things that happen when you first experience difficulty breathing. Remember, that's how your body compensates. That's how we talked about it earlier. And when you stop doing those things is when shit gets bad, right? I'm sorry. When things get bad, right? And that's when the blood pressure starts to go down, and that's when the respirations start getting slower. Somebody tell me what silent chest means. I hit on it hard. What? Yeah, the chest stops moving. Why did it stop? Why aren't they moving air anymore? Yep. They used all their energy, right? And if an asthmatic ever tells you they're tired, what's about to happen? Good. These little ditties are going to help you with the national, of course, but that's going to help you on the street more than anything, okay? All right. Common signs and symptoms. Gurgling may be heard even without auscultation. Every time the patient breathes, an auscultation crackles or sometimes wheezes, may be audible. Patients may cough up frothy sputum, usually white, but sometimes tinged pink. We've already covered that. That's going to be your 15-foot assessment as you're walking in the door and you look at your patient. You're looking for guns and other BSI scene safe stuff. When you look at your patient, that's going to be the sick or not sick stuff that we were talking about, okay? Assess and treat for inadequate breathing. High concentration O2. Keep the patient's legs in a dependent position, and CPAP can be used to push the fluid back out of the lungs and into the capillaries. Cool? Cool. All right. All right, this is a question for you guys. Might it be possible for a patient to have multiple respiratory disorders? What's that? Yeah, sure. Yeah, you can have multiple things going wrong with you. I mean, if you're chronic COPD, nothing says you can't get pneumonia too, right? Could a person with an underlying diagnosis of COPD? Yeah. So, can you also have pulmonary edema and COPD? This answer is the same as the question on top. Yes, you can have multiple issues, um, but COPD and pulmonary edema second to CHF are going to look very different. In a patient with COPD and pulmonary edema, what do you think you want to do for this patient? Let's just say you get on scene and they look like crap. Their pulse ox is in the 70s. They're not getting but 2-word sentences out and they're tripoding. Yeah. Probably CPAP, right? You know, there's yeah, we'll get into that stuff later, but good. All right, pneumonia, an infection in one or both of the lungs caused by bacteria, viruses, or fungi. Results from inhalation of certain microbes. Microbes grow in the lung and cause inflammation. This is similar to what we already talked about earlier with an asthma exacerbation, right? The patient inhales junk, and then they cause this big inflammatory response and causes just a whole lot of gross stuff inside their chest, right? All right, signs and symptoms of pneumonia: shortness of breath with or without exertion, coughing, fever and chills, and chest pain, often sharp or pleuritic, worsening on inhalation. All right, so chest pain that gets better when you move them around might be respiratory. Chest pain that doesn't get better when you move them around might be cardiac. Okay. All right. Headache, pale, sweaty skin, fatigue, and confusion. Treatment. For us, it's mostly supportive. In emergency medicine, we treat emergencies, right? Life threats. Okay. So that's why the care for pneumonia is mostly supportive. Maybe a nasal cannula, non-rebreather if they're lucky. But we do emergent medicine. Okay. Assess for and treat inadequate breathing. Patient is hypoxic, administers oxygen. EMS is all about fixing problems when you find them. You do it in certain orders, A, B, C's, and your primary and secondary assessments. But as you come across problems in your assessments, fix them. Okay. EMTs that can apply CPAP to these patients. Pneumonia can be severe enough to cause inadequate breathing and require artificial respirations. Bagging, right? All right. Spontaneous pneumo, lung collapses without injury or other obvious cause. Higher risk for this condition are patients with COPD and a history of smoking at the highest risk. Tall, thin people. That's called Marfan syndrome. Don't make that joke around them because they don't like it. I did that. I made a mistake once. I told my buddy he probably had Marfan's. He didn't like it because he'd heard it before. But the reason why tall and thin people have spontaneous pneumothorax is they grow too fast, and then they can develop tears in their lungs, right? So what are some signs and symptoms of attention pneumothorax? It's important for you guys to know this. Good. Anything else? Good. Anything else? No, yeah, sure. JVD, you guys know what that is? The JVD, right? And that's going to be because the pressure that's building up in the chest is pushing down on the heart, which causes all the blood to back up into the portal, not in the portal vein, into the, what's the main vein called? Yeah, thank you. In the vena cava. And that's what attaches to the right atrium. And that's going to back all the way up into your jugular vein. Make sense? Okay. Spontaneous pneumo, sharp pleuritic chest pain, shortness of breath, easily tired, low oxygen sats, cyanotic, tachycardia, tachypnea, decreased or absent lung sounds on the side with injured lung, with worsening JVD and hypotension. What causes the hypotension? What's that? What causes the low blood flow? Yeah, but what caught? Why? So do you guys remember what the contraindications for CPAP were? Right. And why does CPAP cause low blood pressure? Because it builds pressure in your chest, right? So if you have a pneumothorax, you essentially have a hole in your lung, and then all the air is coming in and going out that hole, and it's getting trapped, and it's pushing all of the organs to the other side. That's what causes the JVD. But that increased pressure that's in your chest that you can't remove is causing the change in heart rate and the change in blood pressure. You guys got that so far? I know the pathophys is hard, but we were talking, and a lot of the new EMT national tests are going to want to know that you guys know this stuff. Okay. So,
About why
all right. When in doubt, call Mr. Perry. Contact ALS immediately. So, as you guys do this job more and more and more, and you get really good at that 15-foot size up of your patient of sick, not sick, you're going to get much better at realizing I need to call advanced life support faster. Okay. Is anybody working at a service that is just EMT? It's basic ambulances. Is anybody going to work at one of those? Well, that's good. So you'll have the ALS right there. And that means they have to do everything. All right. Administer O2. CPAP is contraindicated. Transfer for definitive care as patients frequently require a small catheter or a large chest tube. So basically all that, you have the hole in your lung, and that's where all the oxygen will go, where all the air will go, and it just gets trapped in there. Doc cuts a hole in the rib cage, it puts in a chest tube, and that lets all that air back out. It allows that lung to reinflate. Cool? Cool. All right, PE. You brought up blood clots earlier. Okay. So depending on where the blood clot is at, if it breaks away, does anybody know the difference between embolus and what's the word I'm looking for? A thrombosis? So thrombosis is just a clot that doesn't move. An embolus is a clot that moves. Okay, or something. It's some. So pulmonary embolism, depending on where it's at, can break free, make its way up through your vasculature into your right atria, right ventricle, pulmonary artery, and then when it makes its way into the pulmonary artery, it stops blood flow, and that messes with the Q part of our VQ, right? You have ventilations and perfusion. You have to have both in order to provide the body with oxygen. So if you stop the blood flow, the patient dies. Okay. And that's what a pulmonary embolism is. It's DVT. Lying down, these are reasons: lying down, sitting in the same position, having active cancer, having a limb immobilized in a cast. Other big reasons that call it DVT: long plane rides. People that travel overseas all the time, they sit on their butts for 18 to 24 hours a day on the plane ride, and the blood collects in their lower extremities, and that causes a DVT. Also, prior surgeries. If they just recently had a surgery, you go to a house, who was talking that just recently had a surgery, a patient that just said, was that you? Yeah, that's a big thing you should worry about as an EMT, because they just had surgery, and if the patient clotted and then blew the clot loose and they're having difficulty breathing, that's the first thing you should think of. In EMS, we don't care about the continuum of care as much as we care about the big and bad, right? What's going to kill them now? And then we fix it. And that's what's awesome about our job. All right. Other signs and symptoms, all the things. It's difficult to differentiate in the field, but knowing what you know now, you got a guy who just had surgery and all of a sudden he's got sharp chest pain and he can't breathe. He doesn't smoke. He doesn't have any of those other disease processes. It's probably a PE. And PEs look weird. If you ever get on a patient, you can't figure out why they can't breathe or why they're having a trouble. PEs are always the last, like it's a PE. If you ever don't know what it is, it's a PE. I'm telling you, I promise, every time. Transport to definitive care. All right, epiglottitis. I want to talk about this one because if you treat it wrongly or your medic treats it wrongly, the baby dies. Okay, so let's talk about epiglottitis real quick. Let's see what else it says. All right, these are going to be your signs and symptoms: sore throat, painful or difficulty swallowing, tripod position, sick appearance, muffled voice, fever, drooling, and stridor. Okay. The one thing I want you guys to remember about epiglottitis is it will come with a fever that comes on fast. It comes on fast. And then next to what you guys are all writing down epiglottitis right now, right? Next to it, I want you to write croup, C-R-O-U-P. Croup also comes with a fever, but it comes on slow over days. Epiglottitis has drooling. The kid will not want to swallow at all because his throat hurts so bad that he's just going to drool. Croup will have something called like a seal. It'll have stridor. You'll have that stridor, that upper airway obstruction, and you'll have a seal-like cough. These are the big differences between the two. The reason I say this, the reason why I say it's such a big deal for you guys to memorize this stuff, because the medicine that your medic, if he gives it to epiglottitis, the baby's airway shuts up, and then the next thing you're doing is cutting the baby's throat and finding an airway by doing a crike. Okay? So epiglottitis is nasty. You don't want to mess with this kid. At best, humidified oxygen. You don't want to piss them off. You don't want the baby to cry. You don't want to secure them in a way that makes them uncomfortable. Because if you irritate that throat, the trachea will close up. And the next thing you're doing, the next thing your partner is going to be doing is putting a needle in that baby's neck to try and get it oxygen. Croup, though, on the other hand, there's a medicine called racemic epi. It's just nebulized epinephrine. It's just nebulized adrenaline. You give that to croup all day long. But that same medicine, if it given to epiglottitis, is bad, bad news. And in EMS, we should never, let me take that back. Racemic is indicated in stridor, even if it's epiglottitis. I would never, as a paramedic, give an epiglottitis racemic epi because I think any irritation, the next thing I'm doing is trying to find a rescue airway on this kid. But for you guys just need to memorize what the differences are and how they present. That way, you know not to jostle this kid around at all. If the kid cries, if the kid's uncomfortable, I can't emphasize enough. You're gonna crash that kid's airway, and then your partner's gonna be doing lots of other shit that they won't want to do. Okay. All right. All right, keep the patient calm and comfortable. Don't inspect the throat. You can give high flow O2. Don't alarm the patient. Transport. I'm serious. I've had an epiglottitis kid, and I took her to the hospital in mom's arms on the stretcher, and we just drove slow. I didn't want to piss that kid off. Croup, caused by a group of viral illnesses that result in inflammation of the larynx, trachea, bronchi. Tissues in the airway, particularly the upper airway, become swollen and restrict the passage of air. That's an upper airway obstruction. What breath sound are we going to hear? You. Good. All right. Loud barking cough. They're going to sound like a seal, not a Navy SEAL, an actual SEAL. Right? Associated breathing difficulty is a Navy SEAL. He'd have to write a book. No, nothing. I thought it was funny. All right. All right. Associated breathing difficulty typically resolves when the child moves to an upright position. Inadequate breathing indicates the signs of hypoxia, cyanosis, altered mental status, etc. All right. Signs of significant breathing difficulty in respiratory stridor. I don't think it's going to say it, but remember the onset of fever. Croup onset is slow. Epiglottitis is fast within the past few hours. Okay. All right. If there's signs of inadequate breathing are present, fix it. Initiate artificial respirations and transport immediately. If the patient is in respiratory distress but is breathing adequately, call ALS and initiate gentle transport. All right. Consider supplemental oxygen if the patient is hypoxic and allow the patient to remain in a position of comfort. If you're not sure what you're looking at, don't piss the kid off. That's pretty safe. All right, bronchiolitis. Small airways become inflamed because of viral infection. Most common cause is respiratory RSV or, oh, it's called that. Okay. So same type of thing. You get junk into the airway and then the body reacts accordingly to it, right? Viruses, we don't have cures for viruses. We can only provide supportive care and medicine and things like that. What do we use to treat bacterial infections, guys? Antibiotics. You're exactly right. All right. Signs and symptoms commonly associated with other cold-like symptoms such as runny nose, fever, and general illness. They typically progress over a few days, worsen over to include respiratory distress. Common for multiple children in the house to be sick with similar symptoms. It's like, who has kids? It's the crap they pick up at school. All right, they bring the crap home, and it's just the crud they get from just being around other people with it. It could cause significant respiratory distress and progress to inadequate breathing. All right, treatments: artificial ventilation. If the patient's hypoxic or shows signs of hypoxia, treat with supplemental oxygen. What's wrong? Oh, okay. Consider using a bulb syringe to suction the nose if it's obstructed by mucus, and clear the nose of an infant can significantly improve minute ventilation. All right, cystic fibrosis is a genetic disease and it's nasty. People who have cystic fibrosis don't live very long. It causes thick, sticky mucus accumulating in the lungs and the GI system, and mucus can cause life-threatening lung infections and serious digestion problems. So just too much junk in their chest. These are the signs and symptoms for cystic fibrosis. It's a lot like asthma or bronchitis, except there's coughing up blood. I didn't see that till just now. All right. Treatment, often best resource for baseline assessment of the patient. Patient or caregivers can often guide the treatment. All right. Infection. All right. Viral respiratory infections affects more than 17 billion people a year. Often starts with sore, scratchy throat, seizing, fever, chills, spreading to the lungs, causing shortness of breath. The cough can be persistent and may produce yellow or greenish sputum. All right. We provide supportive treatment, supplemental oxygen for hypoxia, bronchodilators for wheezing. What medicine do we have that's a bronchodilator? Good. All right. Infection is viral, cannot be helped by antibiotics. Good hygiene can prevent viral respiratory infections. So, who's been on the ambulance so far? Are any of our patients clean? Most of them aren't. All right. The prescribed inhaler. You want to take a quick break real quick?
Yeah.
All right, guys, 10 minutes, please.
Not acclimated to the no sleep yet, okay? I'm still trying to function life. Sorry.
All right, everybody get seated. Finish this up.
All right, guys.
All right.
You're actually the one that actually understand those, so that's cool.
You're understanding the things? Good.
Being able to follow.
Who was it yesterday? Was she a lifelike? No?
What was the girl yesterday? What was she lifelike? No, she's trauma.
Hmm?
The instructor lady.
Oh, Lexi's like.
Oh, yeah. Lexi, she's a sweetheart.
No, yeah, no, she's
Yeah.
like just.
Yeah.
For the link things sometimes.
Okay. I try and explain them in a way that all of us understand. I mean, that's not All right, so hey guys, let's talk about that real quick. You're about to take a medication quiz. Well, I don't know when they're going to have you take it, but it's really important that you memorize all the meds you're allowed to give. Can anybody give me a reason why you would not want to mess that up?
Because you could kill someone.
Yeah, that's a good reason. When I was in medic school, my instructor gave us medication quizzes as we went along, and he says we had to have 100%. And if we didn't get 100%, he would go to our preceptors and tell them, Brandon is not allowed to give this medication. And that shit is embarrassing. So yeah, you don't want to kill anybody, but it is embarrassing to make med errors. Okay. So let's talk about albuterol real quick. Does anybody know what the dose of albuterol is? What?
Well, we're not quizzing during class time, so.
Well, we're not allowed, but it's part of the class though.
Go for it.
I mean, are they taking the test now? Do you want them to take it now?
Yeah.
Okay. Well,
It shouldn't take 5 minutes.
okay, go ahead and knock that out, guys. And then we can talk about it. Go ahead and knock that out. Is it open book or closed book?
Close book, close paper.
Okay. Sorry. What?
Plain as best.
Nice
Like
thing
he
is,
said,
it's
these,
first one.
you will have and better have these memorized
Yeah, there's no way.
because they're gonna be on your tests, they're gonna be on your registries, they're gonna be your partner in the back of the ambulance, giving the drugs, and if you don't know what you're doing, you're not gonna do it. And then you're failing your class.
Can I see one of those? Please? Oh, it's just one med?
Yeah, they're just doing.
Are they doing
they've got-
albuterol?
they-
Oh.
No, they all got something different.
Oh, did they? Okay. Who got albuterol?
I thought she had one.
Okay. I'm glad I didn't go over that then. I almost went over that.
I was like, wait.
I almost did it in the beginning of class. What's that? Oh,
This is the one I did not read. Why did I pick?
two agonists.
Sorry,
Okay.
it's yours.
Oh, so yeah, it's a beta 2 agonist. It means it opens up those bronchioles, right? What is an indication for albuterol? Wheezes is the big one. Bronchoconstriction is the main one. Shortness of breath. There are medics out there who have a real problem with throwing albuterol at everything, as far as respiratory goes. And it's kind of a long story, but I had an epiglottitis kid once, a couple years back, and the fireman on scene was really adamant about giving this kid albuterol. And I nicely, professionally told him no, but he pushed me all the way to the ambulance about giving this kid albuterol, and it could have irritated his throat and crashed his airway. That's the Reader's Digest version of that story. What are some contraindications for albuterol? Allergy is the main one. Albuterol is not endogenous, which means it doesn't occur naturally in the body like epinephrine does, but it has a similar action. So with albuterol, the big thing you want to worry about is that sympathetic effect that it can cause. And you don't want to give a lot of it to the elderly. Because if you give too much albuterol to the elderly, you're going to shoot their heart rate through the roof, and you're going to cause effects that you don't want. Okay. Anybody have anything to add to albuterol? Did you figure out the dose? All right. It's 2.5 milligrams in a 3 ml bullet.
Where they're gonna get dealer, so it's a metered dose,
Mm-hmm.
1 to 2 puffs.
Mm-hmm. Okay. At the national level, you guys are allowed to make nebs. And on an ambulance, it comes in 2.5 milligrams in a 3 ml bullet. Do you guys know what the bullet is? Do you know what I'm talking about? It's a little plastic bullet. It's got fluid in it. You pop the top off and you fill the nebulizer up with it. At the national level, you're allowed to make those. In Wyoming, you're not. But because you're taking the national registry, you have to know these things. Okay. So, um, so precautions. Oh, who had nitro? Nitro is also pertinent to respiratory problems because we can give nitro for CHF. Okay. What was the dose for that? 2 to 4 what? No, you'd never figured it out. 0 point, what it, okay, 2 micrograms. Micro.
See the 0.4 milligrams.
Mhm.
It's for
Yes, sir. Yes, sir.
4 micrograms.
So if you write it in a decimal, it's milligrams. If you write it without a decimal, like 2 to 4, it'd be micrograms. There's 1,000 micrograms in 1 milligram. You guys should write this down. There's 1,000 micrograms in 1 milligram and 1,000 milligrams in 1 gram. And then there's 1,000 grams in 1 kilogram. And that's important if you're whatever. Okay, there's 1,000 micrograms in 1 milligram. There's 1,000 milligrams in 1 gram. And there's 1,000 grams in 1 kilogram.
What was the dose that you said that was? 4 micrograms?
Yeah, 4 micrograms is the
Is the 0.4 milligrams of nitro that you're giving them. You move the decimal point over 3, so it actually 400 micrograms.
yeah, that's right. Sorry, 400 mics. Yeah. Anyway, and as an EMT basic, you're not allowed to give nitro in Wyoming. But if what's the one thing? Think about what nitro does. What does nitro do? Exactly, right? It opens up the blood vessels, right? Causes vasodilation. You should never, ever, ever, and this is a rule. It's not a, it's an unwritten rule, but it's still a rule. You should never, ever, ever give nitro without an IV already started. Because nitro is funny when you believe it's sublingual. I've seen it drop the systolic 20 points. I've seen it drop the systolic 80 points. And if you tank their pressure, the only way to get it back up is fluid. Okay? Yeah, nitro can be given in lots of different ways. There's patches, sublingual, there's IV infusions. Nitro is lots of uses. But for EMS, it's IV infusions and the pill and the sublingual.
The way you give it or assist giving it, and like you said, normally this is why it's a medical control thing. You're going to have to call medical control before you give the nitro because it can't tank their pressure. But the way you'll give it is under the tongue.
If you show up on a chest pain and Pawpaw has already taken 4 or 5 of his own nitro, the reason you have to call medical to control is because doc's going to want to know what his blood pressure is before he says yes to you. Because if you tank it as a basic, you can't start IVs. So you've killed your patient. Make sense? So, you're good. Oh, yeah. Anyway, okay. Let's talk about the prescribed inhalers. Meter dose inhalers provides a metered, exactly measured inhaled dose of medication, most commonly prescribed for conditions causing bronchoconstriction, asthma. Most of your kids with asthma are going to have their own type of inhaler. Most of the time, it'll be albuterol. Sometimes it'll be a mix of albuterol plus Atrovent or other things. Am I turned on? Oh, you're good. All right. That's what it looks like. You're allowed to help a patient with their prescribed meter dose inhaler in Wyoming. All right. Before you administer the inhaler, make sure that it's the 6 R's. You guys need to memorize it. It'll be on the national. The 6 R's: right patient, right time, right medication, right dose, right route. and then check the expiration date. Shake the inhaler vigorously, and the patient it has to be alert enough to use the inhaler. Go ahead.
Yeah, that's only showing 5. The last
Yeah,
one's way
so the
up.
last thing is right.
Oh, right. Yeah, make sure you're giving it. Make sure Billy isn't using Jamie's inhaler. All right, use the spacer device if the patient has one. What that does, what the spacer device does, if they have one, why it's important to use, is because it helps atomize the medicine before it goes into their chest. All right, sure, the five rights, 6 rights. All right, there's your spacer device. All right, this is how you have them do it. You have them exhale deeply, have the patient put their lips around the opening, press the inhaler to activate the spray as the patient inhales deeply. Make sure the patient holds breath as long as possible so the medication can be absorbed. However, dramatic pause. We go to calls for people who are sick. Some people are going to have a hard time holding their breath. Okay. So just be aware that not every patient's going to be perfect and they're not going to be able to do exactly what you tell them to because they physiologically can't. All right. Small volume neb. All right. Medications used in meter dose inhalers can also be administered by a small volume nebulizer. All right. Nebulizers run oxygen or air through liquid medication. Patient breathes, vapors created. This is what would be on your ambulance, guys. What liter per minute or oxygen? Yeah, what liters per minute of oxygen are you going to run to those nebs? Does anybody know? Perry. 6. Yeah, 6 to 8. 6 to 8. Perfect. Oh, yeah, you said that. Good job. All right. Produces a continuous flow of aerosolized medication that can be taken in during multiple breaths over several minutes. Gives the patient greater exposure to the medication. All right, so there it is, right? I personally do not like that setup because on the ambulance, the patient's going to have to hold it themselves so you can do patient care. You can actually pull the nebulizer part off and hook it to a non-rebreather mask. And then you just put it on their mask and then they on their face and they just breathe it in while you're going down the road. Okay. Yeah, the simple mask. I don't, yeah, I don't like this system. It's swell. Chances are, if your patient has difficulty breathing, they're going to the hospital. So the mask works better. Because you put it on them, help them to the cot, get them in the truck, and go. All right. Chapter review. Respiratory emergencies are common complaints for EMTs. It's important to understand the anatomy, physiology, pathophys, assessment, and care for patients experiencing these emergencies. Patients with respiratory complaints, which are closely related to cardiac complaints, may exhibit inadequate breathing, rapid respirations, indicate serious conditions, including hypoxia, cardiac, respiratory problems, and shock. All right, very slow and shallow respirators are often the endpoint of a serious condition and are a precursor to death. How many times have I said that throughout the night? When they start to slow down is when you should worry. Not worry per se, but know you're about to do more work. Okay. When they stop compensating is when, respiratory rest comes. Okay. All right. History usually, the mystery is in the history. Don't ever forget that. A good assessment and a good history is going to tell you a lot about what this patient is going through. The majority of your calls aren't going to be new onset. Most of your seizure patients have a history of seizures. Most of your asthma patients have a history of asthma. It's not common for you to, you're not going to commonly go to new onset stuff. So the mystery is in the history. If you figure out what's going on with them, you can treat it appropriately. All right. Significant information about the patient's condition, in addition to determining a pertinent past history and medications, determine the patient's signs and symptoms with a detailed description, including an OPQRST and events leading up to the episode. All right. Important physical examination point includes checking the patient's work of breathing, inspecting accessory muscle use, gathering pulse ox readings, assuring adequate and equal lung sounds are bilateral, examining for excess fluid, lungs, ankles, and abdomen, and gathering vital signs. It's important to notice, you remember a few slides ago where it said there's a huge similarity between respiratory issues and cardiac issues. If a patient has swollen legs, you know they have a heart problem because that means their left heart has failed and the blood pressure has gone up and it's pushing all that edema into their legs, right? No, the right heart. I'm sorry. I got that wrong. If the left heart is backed up, the lungs fill up with fluid. So you look confused. Okay. All right. Several medications are available that may help correct a patient's difficulty in breathing. Determine if the patient's breathing is adequate, inadequate, or absent. Choose the appropriate oxygenation or ventilation therapy. Consider whether to assist a patient or administer respiratory medications. Do you have the protocols and medications that may help this patient? Does the patient have a presentation and a condition that may fit these protocols? A lot of times, the nebs that we have on the truck have way more medicine in them than what they have in their inhalers, and it'll work way better. Because our protocols state we can give 2.5 milligrams. With their meter dose inhaler, they might only get half or 1 milligram. All right. Are there any contraindications or risks to using these medications in my protocols? All right. What would you expect a patient's respiratory rate to do when the patient gets hypoxic and why? Okay. In the beginning, it's going to increase, right? Tell me why. They're hungry for, I like that. What would you expect a patient's pulse rate to do when the patient gets hypoxic? You. Good. Why? Sure. Not being able to breathe causes stress, right? That's why the heart rate's going to go up. All right. Listen, signs of inadequate breathing. I'm just going to go around the room. Tell me one sign of inadequate breathing. Sure. Sure. Good. So good. Huh? Crunching? Like in the lungs? Like air? Okay. Okay. Crackles. Crackles. Snap, crackle, and pop. No sounds? Like silent chest? I like it. Yeah. Good. 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 All of those are, I mean, yeah. Do you want to go again? Oh, okay, cool. All right. What would you expect to assist a patient with their prescribed inhaler when they are experiencing congestive heart failure? Why or why not? All right. That's kind of a deep question, guys. Do you think you're ready for it? Would you expect to assist a patient with their prescribed inhaler when they're experiencing a congestive heart failure? Why or why not? Ooh. What's that? No, you guys talk it out. A lot of people who have congestive heart failure will can have COPD at the same time. So you had me in the first half. So no, I mean, okay, so you would have to figure out what's going on with them. Okay. There are different signs and symptoms for both COPD. We're going to just use COPD versus heart failure. Okay. If they're a heart failure patient, some signs and symptoms would be swelling of the legs, fluid in their lungs. Do we give albuterol for fluid? We give albuterol for wheezes and bronchoconstriction, right? Now, the inflammation that's caused by the fluid can cause bronchoconstriction, but for this part of the conversation, this patient has got pretty clear lungs. Would you give albuterol to this patient? Would you give nitro? Why? If you're going to be right, tell me why. Okay, so nitro is indicated in CHF because one of the side effects of congestive heart failure and exacerbation, the blood pressure is going to go up, right? And what is nitro indicated in? Really?
You're all
Really?
staring at him even.
What is nitro indicated in? Good, right? If someone's having a CHF exacerbation, they're going to have chest pain. Okay. So you give the nitro to relieve that chest pain, lower the blood pressure. But what should you always have before you give nitro? Get out of here. I just said this like 20 minutes ago. An IV. Good. Good. An IV. Never give nitro without an IV. But you could flip that, guys. This could be a COPD patient and a CHF patient, but he has wheezes now. He doesn't have any swelling because he's taking his Lasix. He's doing good on his heart meds. Then you would want to give him albuterol. Does that make sense? That question can go either way. It's how you tell the story and articulate what your response is. So if you're going to be right, you have to explain it. Okay? List some differences between adult and infant respiratory systems. Go ahead. Good. Oh, yeah. Yeah. Mm-hmm. Sure. Sure. So some differences between adult and infants. Physiological differences is like kids got large tongues, they have big puffy cheeks. They have their anatomy compared to an adult is so much bigger up here, right? So you got to be, and they've got floppy epiglottises, they've got narrower tracheas. They're just, it's gnarly how different little ones are compared to adults. All right, here we go. We're going to talk this one out real quick. 72-year-old female complains of severe shortness of breath. Her husband notes that she's confused. You note a respiratory rate of 8 breaths per minute and cyanotic. Patient has a history of COPD and CHF. We already did this. Discuss the treatment steps to assist this patient. So you got to figure out what's causing the issue, right? And that's why it's important to know the different the physiology between the etiologies of the disease processes, right? You got to know what the signs and symptoms of both diseases are so you can treat it appropriately. Make sense? Cool. And don't copy this. All right. That's the end of that, I think.
Goes through all the pictures and stuff.
Oh, okay. Yes. Yeah, just YouTube that. Look up lung sounds and just listen to them and get used to listening to normal lung sounds. That way you know what it sounds like, and then you'll know when something doesn't sound right. Do you want me to go through this stuff, the appendixes? All right. The position of the diaphragm in each 4 images is as follows. Relaxed stage. Oh, we already looked at the pictures, didn't we?
Yeah, this just
Okay, I explained that. Well, I don't, is my clicker turned off?
oh, sorry.
You're fine. We already covered most of this. All right, real quick before we call it a night, I want to go over primary assessments and secondary assessments real quick. I want to show you guys a trick that if you memorize this, you'll get through your psychomotor without any issues. And I still use it today on the street for my assessments. Okay. So how did you guys learn your primary assessments? What did you guys learn about it? Somebody speak up, please. Okay, so you guys learned it by the grade sheet, right? Okay. Well, I'm gonna show you something. I need another Zen though. Yeah, talking to you guys has really been stressful. You guys talk way too much. You interrupt me the whole time. The what? I never saw those. Did they have those? Gross. I would probably die. All right. All right. So this is your primary assessment. M, A, B, C, D, E, F, G, H. I know every single one of you can see a pattern there, right?
Yeah.
Right.
The alphabet.
Minus the M. Minus the M, right? This is your primary assessment. What's the M stand for? Massive bleeding, life threats, right? So now with your primary assessment, like I said earlier, you fix the problems that you find. Okay. Don't move on to the next thing because the way this order works is the next thing is not as important, is not as bad as the first thing. Just go with me on that. Okay. So if you walk up on a patient who was just in a car accident, they were ejected and they're bleeding out, what should we do first? Stop the bleed, right? So tourniquets, pressure dressings, all the rad stuff that we do, right? Stop the bleed. What's A stand for? Good. Airway. B. Okay. And I know you guys already know how to fix these problems. See? D. Disability. What I mean by disability is their AVPU level. You guys know what AVPU means? What? Anybody know what AVPU means? It's their alert status, right? AVPU, alert to pain. Oh, verbal, pain, unconscious. That's the 3 levels of disability. Okay. You can check that with a nice solid sternal rub. Okay. E, expose. E stands for expose. In cases of trauma naked, right? You guys hear that term yet? Okay. F, Fahrenheit, their temperature. I'm not going to try and spell that. G, think about in your what tools, what assessments can you guys check for that starts with a G? Huh? GCS? Nah, no. What was your medication? Good. Check sugar. And H is head injuries. Okay. This is your primary assessment. Okay. Let's talk. If you go through and do this for your primary assessment, it will cover every one of those skills checkoff sheets. Every one of them. And some might not say to check a glucose. I don't remember which ones say what, but if you do that on every one of your patients after BSI is seen as safe, after you've called for ALS, all that other stuff in the top, when you go into your primary assessment, you cover all of that and you verbalize it to your grader, you will pass that part. Now, do you guys want to go over secondary assessments real quick? All right. We're going to have to all stand up and go stand over there so we can go over something real quick. What's up?
So that,
So that is airway.
okay.
Assess the airway and breathing. So, and if you, And if you fix the problems as you find them, you'll do this, right? So if you get to A and the patient is not breathing right or is not breathing adequately, and you decide to bag them, you'll get the 3 points for that. You see what I'm saying? You gotta, as you go down and check the box. Oh, you're good. All right, guys. You want to be my patient?
Sure, why not?
Cool. Lay down on your back. Pull your hat off for me, will you? Okay, as far as your secondary assessment goes, the secondary assessment is your head to toe assessment. It's find the BB, find what's wrong with the patient that you can't see just by looking at them, right? So you guys can make up your own secondary assessment. What you have to make sure though is that you cover everything. All right. And you can do it my way if you want. You can do it whatever way you guys feel like doing it. But I always just lay your head back. All right. So I've already gone through A, B, C, D, E, F, and G. But as I go over my secondary assessment, I'm going to cover some of those things again. Now, what I'll do is I start at the chin. I work my way up over the head, around the head, down the body, groin, armpits, back type stuff. Okay. So what I do is I check down here. I look down here at his mandible. The mandible is the jaw. The reason I remember that is because, man, it sucks getting punched in the jaw. Okay. So the mandible. I open the mouth. Relax, bud. All right. All right. The airway there's only two things. Is it open or closed? Okay. That's it. Is it open, closed, and patent? I'm sorry, patent. Then I move up to, and you put your hands on them. Okay. Scoot over a little bit. So you put your hands on him, open the jaw, make sure there's no teeth in his airway. If there's blood and emesis or whatever, if there's stuff, and you fix problems as you find it, right? So if you open the jaw and his mouth is full of junk, clean it out. Suction, finger, whatever. Probably not a good advice to stick your finger in somebody's mouth. Okay. And then you move up around the nose and make sure his nose is intact, his cheeks are intact. And then you look at the eyes. Are his pupils blown? Head injuries are going to blow out pupils. When the brain swells and shifts, it's going to blow out pupils. Okay. And a fun fact about orbitals, that's the bone around your eyes, they're circles. When they break in two places. You don't ever have just a single orbital fracture. If it breaks here, it'll also be broke up here because it's a perfect circle. Make sense? So you move your fingers around his orbitals, stuff like that. Then you run your hands through his hair and you're looking for blood, looking for anything that doesn't feel right. All right. Skull fragments, whatever. You come around and you look at his ears. Okay. Bruising behind the ears is called battle sign. And that's indicative of a head injury. That means there's bleeding in the brain. Okay. And then you come down into his throat and you're looking at his throat. You're looking for JVD and tracheal deviation or anything that doesn't look right. Oh, you also look at his ears. Head injuries, fluid will come out of the ears sometimes. And it's usually clear and it tastes like bananas. Don't taste it. I'm just kidding. All right, after the throat, you move down here and you feel the clavicles. Physically put your hand on his clavicles. There's a lot of vessels, blood vessels behind the clavicles. And if they break in the wrong way, they can cause extensive bleeding. Okay? And then you come down into the chest and you feel the chest wall. Does anybody know what the definition of a flail chest is? All right, it's like two or more broke. Do they? So basically with a flail chest, it's going to do the opposite. The patient will inhale normally on the good side of the chest and it'll raise. On a flail chest, it'll sink. Does that make sense? Later, I want you guys to YouTube breath sounds and what a flail chest looks like because it's freaking weird, okay? Come down into the chest wall. Make sure it's sturdy and there's no broken ribs. Then when you guys go over palpating the abdomen, okay, quadrants, 1, 2, 3, 4. And then you come down and you check for a stable pelvis. He's naked. You need to look at his perineum, which is the space between his genitals and his anus. When men have pelvic trauma, they develop something called Cooper nail sign. And their scrotum will swell up like a bowling ball with blood. On a woman, her labia will swell up and it'll be noticeable, but it'll show that the patient has a possible broken pelvis. And then you move down and you check the femurs. What you do is you apply pressure and then lift on one. So you come on here, and if he's conscious and it's a broken femur, he's going to scream. And you're going to know that that's not a good femur anymore, okay? So you do both sides. And then you check the short bones. And then since he's naked, you check pedal pulses. You guys know what those are? Okay, you ensure that you've got good circulation to the feet. Then lastly, I'll come up and I'll check his armpits because there's a lot of important vessels that go through your armpits. And if he's bleeding, he could be bleeding out from there, right? And then I'll check his pulses in both of his hands. Now, you can get up. The last thing you're going to check is his back. When you go to put the patient on the backboard, that is the only time you're going to have to look at his back. After that, you're never going to look at it again. Okay? So when you go to roll him, you're going to look down his neck, put your hands on his neck, and feel for step off. You're going to feel for spinal vertebrae that are shifted. That's step off. Okay? You're going to feel for it. Run your finger down his back, and then put him on the backboard. When you go to lift him and put him on the board, that is the only time you're going to get to look at his back. Okay? So as long as you do all of those things with your primary and your secondary assessment, your checkoffs are not only easy, but today I still do that. I still do that whole in my head. I go down the list: A, B, C, D, E, F, G. Make sure. Okay. I once had a car accident where a woman was T-boned on I-25, and because I didn't cut her clothes off in a manner, I didn't remove her underwear. I missed the flail segment and the pneumo because I didn't want to palpate her chest. So that happens. So be sure to do that, okay? Trauma naked is trauma naked. Do what you got to do as far as assessments and then cover them up. Try and protect their dignity. But it has to be done. Or else you do what I do and you look like an idiot in the ER because you missed something. Okay? All right, cool. Good job, guys. Every patient for these sheets, and I promise you'll do just fine in psychomotor. I think that's about time, huh? I can't believe